Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckville and I will be serving as your program facilitator and will present your questions to our experts. Tonight, you're going to hear from our weight loss specialists as they explore the benefits of bariatric surgery, such as eliminating diabetes and improved fertility, as well as how revision surgery and weight loss medications work. Well, thank you for submitting your questions in advance of tonight, and the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital university guidelines and privacy, we are unable to comment on specific cases. Well, with that, I want to go ahead and introduce our experts for the evening, starting with Dr. Alec Beakley with bariatric surgery and Kate Godovan, bariatric medicine and metabolic medicine. Well, thank you both so much for joining us. And before we dive into the questions, I'll go ahead and give each of you a minute or two to just say hello and provide a little background information about yourself. So Dr. Beakley, we'll go ahead and start with you. How are you doing?
Good. Thanks, Sarah. I'm happy to be here. So I've been at Jefferson since 2010. Before that, I was trained in the U.S. Army. I'm a West Point graduate, so did my schooling on the Army Health Professions Scholarship at Case Western and finished my training 3 months before 9/11. So I had opportunities multiple times to go serve our country as a surgeon, and was originally hired at Jefferson on the trauma service, but the surgeons that trained me in the Army had a weight loss surgery program. So I've been taking care of weight loss surgery patients since I was a wee intern in 1996, and have been doing minimally invasive surgery since 2002, weight loss surgery. I became the chief of the program here in 2018. I still do a week of trauma every month because that's also a big part of my practice. But now I'm mainly being the chief as the weight loss surgery service.
Okay, well, an interesting background, and thank you so much for joining us this evening. All right, Kate, how are you doing this evening?
I'm doing well. So yes, my name is Kate Godovan. I'm a physician assistant. I was trained here at Jefferson, graduated from the program here. I have worked in emergency medicine as well as primary care after graduating. Before kind of moving in, when I was in primary care, I became passionate about really helping my patients truly make lifestyle changes as it relates to their health. So I became certified in obesity and weight management, as well as lifestyle medicine. And then in 2022, joined the program here, and I primarily do medical weight management. So I'm passionate about helping my patients really take an active role in really improving their health as it relates to their weight. So I'm always excited to be a part of these things and answer questions when necessary.
Absolutely. Well, with that, I know we've received a lot of questions, so let's go ahead and just dive into it. So Dr. Beakley, this first question is for you, and it's actually the most popular question that we've received. What are more of the long-term impacts of surgical weight loss options, and how sustainable is the weight loss?
So thank you. So to date, I think the surgical treatment for weight remains the most effective and sustainable long-term treatment that we have. There are a number of different surgeries, and all of them result in sustained weight loss, and that's for a majority of patients. And when we talk about weight loss, we're talking between 50 to over 75% of what we call excess body weight loss, which is the amount of weight above the so-called ideal body weight. And that can be sustained over long periods of time for the rest of the patient's life. And all the operations vary in terms of their amount of effectiveness and amount of weight that we lose, that a patient will lose. But they have benefits based on how the operations are done in terms of treatment of weight-related health conditions like type 2 diabetes, hypertension, obstructive sleep apnea, and a whole host of other diseases that are improved with the weight loss surgery. And so, a lot of patients say, well, I've heard of patients having weight recurrence and regaining all that weight. And while that's possible, it's less likely if the surgery is used as part of a comprehensive program of diet, habit changes, exercise, and so on.
Okay. And as a follow-up there, I guess, what are the qualifications for surgery? And is there a minimum BMI or weight? Is there anything that prevents someone from having weight loss surgery?
Yeah. So the original criteria for weight loss surgery were set by the National Institute of Health. There was a panel, and it was 1991, I think, and we've only recently, as recent as November 2022, updated those requirements. The original requirements were a BMI greater than 40. That by itself qualified the patient, or about BMI between 35 and 40 with a weight-related health condition like type 2 diabetes, obstructive sleep apnea, and hypertension, and there are others. The newer criteria now have reduced that BMI cutoff to 35. So now patients that 35 or above will meet criteria, and patients with a BMI between 30 and 35 with a weight-related health condition now qualify. Now, there are a couple caveats in terms of actual what's happening in the field, and that is that not all of the insurance carriers have adopted the most up-to-date recommendations yet. So some have and some haven't. But by and large, we're starting to see more and more of the insurance carriers covering those new criteria.
Okay. All right. Well, that's great news. Okay. Kate, we will turn to you. What are the long-term impacts of medical weight loss options, and how sustainable is the weight loss?
Yeah, so kind of similar to what Dr. Beakley was saying, any effort that we make to lose weight is with the long-term goal of ultimately improving your health. And so with that, when we have excess weight, it puts us at higher risk of things like high blood pressure, high cholesterol, type 2 diabetes, reflux, these things. And so the long-term impact of medical weight loss is to continue to improve those conditions as we take the medication and reduce the weight, get to a sustainable weight. Some of the medications can even lower your risk of heart disease and things like that. So depending on the specific medicine we're talking about, there's many positive long-term impacts to the medication. And I would say, similarly, it's a lifestyle change in combination with the medication. Whether you're using surgery or medicine as a tool, it's always going to be those lifestyle changes alongside of it to make it continually sustainable. But I would certainly say, as long as you're continuing to follow up with your provider and adjusting the medicine appropriately for what your needs are, it's extremely sustainable.
Okay. And do you have any concerns about long-term side effects for weight loss medications?
I will say, the medicines that we prescribe, of course, I think it's a very safe, FDA-approved, regulated medications that we utilize. I think the biggest thing is to make sure that you're getting the prescription through a knowledgeable clinician who is taking the time to really educate you in how it is a tool and how to change lifestyle with the medication. I think of them similar to other medicines that you would take for a chronic condition. So if you're taking a blood pressure medicine or a cholesterol medicine, you want to become educated on that condition and how you can do the lifestyle things alongside taking that medication in the long term. And you want to keep seeing your provider, because we might need to adjust the medicine. We might need to change the dose depending on what is going on. And we're always assessing the kind of, risk versus benefit of continuing the medication in the, long term, of course. The kind of short-term side effects, it depends on the specific medications. There's over 7 medicines that are FDA approved, but even the newest class of medications has been used for over 20 years, first for the use of diabetes. So we do have some long-term safety in that regard. But I would say the main maybe concern I would have is if you're not taking it with the kind of knowledgeable clinician behind you and educating you and supporting you, because it is a powerful tool at times. We don't want to lose weight too fast. We don't want to not be, eating our protein, drinking our water, moving our bodies, doing things that ultimately will help you to sustain weight loss, make you healthier in the long term.
Okay. And one last question for you. Do weight loss medications require a lifetime commitment?
Yeah, it's a great question. I mean, I think generally, anytime we're intervening for weight management, we have to think of it from a long-term perspective. We know that like quick fixes or short-term things don't necessarily work to keep weight off. And so, weight loss and then weight maintenance is its own thing. And so I think regardless if we're choosing lifestyle intervention, medical intervention, or surgical intervention, you're going to want to continue to follow it with a comprehensive team like ourselves. And again, back to that analogy of taking a medicine for blood pressure or cholesterol, we continue to carry on and take that medication as long as that condition is present. We might change the doses if that condition is not as severe, if we've done some lifestyle changes as well. So similar for medication, it can be used not just for weight loss, but also keeping the weight off and helping you to sustain that weight loss, as one of the biggest challenges in your weight management journey sometimes is keeping the weight off and preventing that recurrence from happening. So yes, I definitely think it requires that lifelong kind of commitment.
Okay, thank you. All right, Dr. Meekley, turning back to you now, can you talk a little bit about what other surgical choices are there other than gastric bypass?
Sure. It's a great question. And, the field is changing in that regard to some degree. So the weight loss, operations by and large work in two means. All of the modern operations involve something called gastric or stomach restriction, and that's making the stomach smaller. We think that works by a couple means. Number one, in the wall of our stomach are receptors that detect stretch, so that when we're eating and drinking and our stomach is filling up, our consciousness, our brain gets a signal of feeling full. There's also receptors that detect the different types of foods we eat. So patients may notice that something like meat or steak feels heavier. We don't feel like we have to eat as much to feel full versus something like bread or rice or pasta. And all those receptors still work even after we surgically make the stomach smaller. We just, a lot less calories it takes to actually get the signals of feeling full. Now, there's more to the story. We also discovered that probably the more powerful mechanism is an impact on the signals our brain gets for hunger. And so patients have actually said to me after these surgeries more than once, I have to remind myself to eat sometimes. I just don't seem to feel as hungry as I used to. So not only do you feel satisfied after less calories, you tend not to be as hungry in general. The other mechanism that we use in surgery is to bypass some of the small intestine, which is the absorbing surface. So the small intestine is a part of our intestine after the stomach. The average length is about 22 feet. And throughout that 22 feet, food is mixing with digestive enzymes from the pancreas and the liver. And that's actually where the food is broken into molecules and absorbed through the wall into our bodies. What we're actually doing with these operations, we temporarily separate the food from the enzymes. So we have the food routed so it goes down one limb of intestine, but there's no enzymes to break it down, so not much absorption occurs. And through the other limb of the intestine, we have the digestive enzymes, but no food. And they meet farther downstream. So instead of the food and the enzymes only being together for the whole 22 feet, they may be together for only 15 or even 10 feet. And so of what we take in, less of it is absorbed. Now, just like with the stomach, we found there's more to the story. When food reaches farther down into our intestine, there's another signal to the brain of feeling satisfied. And so the patients, again, tend to feel full after less a calorie intake. When we combine those two things, we can really get a very powerful operation for weight loss and treatment of weight-related health conditions. So 4 operations to mention. The most popular right now is actually the sleeve gastrectomy, and that's the operation. That one we're only working on the stomach. So we're just making that stomach from a larger tube into a more narrow tube. It's the shortest of the operations and probably has the least long-term consequences in terms of vitamin or protein problems, too much weight loss. And in fact, the two big issues with that are usually heartburn. It doesn't treat heartburn very well, and some patients that never had heartburn can get heartburn. And that operation has a little bit more chance of weight recurrence down the road. The other operations, gastric bypass, and then a procedure called SOTI and a procedure called duodenal switch, and those may be ones that our audience hasn't heard of yet, but those operations combine the sleeve gastrectomy with bypass of some of the intestine. And those last two are kind of versions of the same thing. And they're very powerful operations that result in more weight loss. They're a little bit more technically challenging to do. They take a little longer, and patients are a little bit more risk of vitamin and protein malnutrition long term. And so we have to be more attentive to vitamin replacement with those.
Okay, well, thank you so much for detailing all of those options and really interesting to hear. All right, we will move along to our next question here. Kate, question for you. For people who have PCOS, does it affect their treatment options?
So for those with PCOS, many have what's called insulin resistance. So this is where the body can overproduce the hormone of insulin. And insulin is kind of in charge of helping you regulate your blood sugar. It's also sometimes can play a role in fertility, and it also can play a role in weight management. So it doesn't limit, your options in any way, but it is an important thing to bring up with your provider, as sometimes there's specific kind of nutrition intervention or specific medications that we might consider that could more in particularly target that. And especially if it's relative to you, maybe if you're in a fertility journey and kind of family planning, that's really important to bring up with your provider, as that might change the medications that we talk about.
Okay, thank you. All right, Dr. Beakley, going back to you here. For weight loss surgery, how long does the process take from start to finish, and how long is recovery?
Okay, yeah, two separate questions. So the process, there is a somewhat extensive process, and that process is put in place to make sure that all patients are as safe as we can get them and as ready as we can get them for the operation. And that the process ranges probably from 2 months all the way up to 6 months. Some of that that longer time is built in. Some insurance companies require patients to see a dietitian a certain number of times and get dietary counseling for up to 6 months. And so sometimes that 6 month period is built in based on an insurance requirement. That's not our requirement, that's the insurance company's requirement. But many patients still take several months to get through all the visits, because we have you see cardiology. Most patients have a psychiatric or psychological evaluation. We have you get a sleep medicine study for sleep apnea. If you haven't had that, there's some labs and x-ray, and then there are a handful of educational sessions with our nutritionists. So it does seem like an extensive process, but it's all designed, and all of these things have been shown to make sure patients are as safe as they can be for the surgery. Now, in terms of recovery, the unfortunate thing is, with all of these surgeries we now do are done almost exclusively with a minimally invasive. That includes even revisions and patients that have had prior surgeries on the abdomen. I would say most of our patients stay just one night in the hospital and are able to go home the next day. And many report being off any requirement for pain relievers within a few days. Many of our patients are fit to go back to work within a week or two. And we lift all restrictions. The main restrictions that we have, the physical restrictions, are no abdominal exercises and no heavy lifting for about the first month. But many patients are back to kind of normal activities within just a week or two.
Okay, great news. All right. Before we hop to the next question, just want to say thank you for submitting your live questions so far. I see a lot coming through in the chat, so we'll get to those shortly. But for the time being, let's hop to our next question here. Kate, question for you. Can those on metformin also take weight loss medications, and are there side effects to taking both?
Yeah, good question. So generally, metformin is a very safe medication. So yes, it can be taken with a lot of the medications that we prescribe to manage weight. Your provider, of course, in your first visit will do a comprehensive evaluation, looking at your medical history, looking at your full drug list, making sure there's no drug-to-drug interactions, talking you through if there were to be any potential side effects. But no, none that come to mind that is necessarily concerning about metformin specifically with the weight loss medicines.
Okay, thank you. All right, Dr. Beakley, for people who get a revision, are they more or less likely to be successful in the long term?
I would say patients that are seeking revision are oftentimes very successful long term. It's important to understand that weight recurrence after a weight loss surgery, the number one reason for it in the majority of studies looking at this issue have suggested that patients tend to stray off our sort of prescribed diet and may have decreased their physical activity. Now, why does that happen? Well, life happens. Patients have injuries, patients have other things in their life that require their attention. That's in the instance of the pandemic, a number of patients said, the gym closed, I was sort of stuck at home, I was working from home, and just those changes in their lifestyle led to some weight recurrence. And so what we oftentimes try to do in patients that have weight recurrence and are seeking revision surgery is refocus on those habits that are going to set them up for long-term success. And as I tell my patient, the harder things for human beings to do is to change habits, because habits by definition are things we do without thinking. To change a habit, we have to think about it every day until that new behavior becomes habitual and we don't have to think about it. And so we try to help with that process. And then patients that do that and really embrace those changes can have great success long-term with revision surgery.
Okay. Well, thank you. Yeah, absolutely. Very difficult to change habits when you're not even aware of them. Okay, Kate, we will turn to you now. Can people who have had bariatric surgery in the past go on weight loss medication?
Yes, absolutely. I think it's, if patients, as Dr. Bigley were just talking about, after bariatric surgery, if they're struggling, whether that's with like a persistent plateau or if it is somebody who's struggling with what we call weight recurrence or the weight kind of creeping back on them, and it could be due to a number of reasons. As we mentioned, the most common is that like life happens, things fall off, you're working on your habit changes. But the medications can be a really great tool in combination with bariatric surgery. And we have a very integrated program. So of course, the surgery team can refer to us, whether it's before that revision surgery, or if it is somebody even leading up to the bariatric surgery, and maybe a little bit of weight loss would make them more successful going forward with the bariatric surgery. So they're very supportive of one another. And I often think of, as they're heading through the kind of bariatric surgery process, sometimes they're kind of sprinting and getting their lifestyle in order. And sometimes people struggle with the jogging pace afterwards, and they just kind of get tripped up with that. And I think sometimes medicines can be something that really gets them back on track and gets them back on the pace that they were seeing before. So definitely think it's a great tool, whether it's a plateau that they're hitting persistently, or if they're struggling with the weight creeping back too.
All right. Well, thank you. Dr. Beakley, can bariatric surgery be reversed?
So the other thing I like to tell my patients, so I have reversed a few surgeries. I can probably count the number of times I've done that on one hand and not use all my fingers. Technically the only operation that we can truly anatomically reverse is the gastric bypass. And the reason for that is the sleeve gastrectomy and the other two procedures, Saudi and duodenal switch that I mentioned, they're based off the sleeve gastrectomy. That involves actually removal of part of the stomach. And once we've detached that part of the stomach from its blood supply and take it out, we can't put it back. So we can't technically reverse the sleeve. We can't reverse the duodenal switch. What we can do is if for example, patients are having nutritional problems, we can oftentimes go in and fix that or revise those so that those nutritional problems are corrected. The sleeve is also of the operations, even though it is irreversible, it is flexible in the sense that it can be converted to any of the other operations as a second stage. But the only one that we can actually truly reverse is gastric bypass. Interestingly, and maybe not surprisingly, when we do that, we see patients have some weight recurrence. And in many cases, that's the desired effect if they've had a problem from the operation itself. And so, but that's technically the answer.
Okay, interesting. Thank you. All right, Kate, does insurance cover these medications? Definitely a question I know a lot of people are probably wondering. And how does someone know that they're eligible for weight loss medications?
Yeah, it's an important question, of course, because we want to understand what are options that we have access to, and sometimes costs can make that a little bit challenging, but a lot more insurance plans are adding coverage as they realize the impact that treating excess weight or obesity can have on one's entire health. So I would encourage you to call your prescription plan. If you go to your prescription card, there's a number on the back for customer service, and you can actually call them and just ask, do they have an exclusion for weight loss medicines, or do they have an exclusion for anti-obesity medicines? If there is an exclusion, that doesn't mean that you don't have medical options. It just is good to know up front. It saves us a lot of back and forth, and so we can jump right into the most cost-effective options as well. We'll talk about if you did want to pay out of pocket for some of the more expensive options, or again, there's been medicines that we've used for years that have, generic options that we could talk about as well. So don't be discouraged if you have an exclusion on your plan. That doesn't mean that there are no medicines that can help you. Still come and see us, but it is helpful to know before your visit. And then in order to know, similar to what Dr. Beakley was saying about qualifying for surgery, you would, plug in your height and weight to figure out your BMI. If your BMI is over 27 and you have a health-related or a weight-related health condition, so that could be actually even just reflux or high blood pressure or type 2 diabetes and some of these things, then that would qualify for your medication, or simply if you have a BMI over 30. And that's because that's where these medications were studied. So we utilize that criteria as that's the population of patients we know the medicines to be safe and to take continually.
Okay, thank you. All right. Dr. Beakley, one last question for you before we turn to our live questions from the audience. Is age a factor for any of the weight loss surgery options?
So you'll see some programs and some places written that patients over the age of 65 are not offered weight loss surgery. That is not our group's policy. We really have no age limit. And this question always makes me think of a patient that I saw when I was a resident that had a fairly advanced or aggressive cancer and in her mid-70s, and she was otherwise healthy, and everyone in her family had lived to their mid-90s. So she was had potentially 20 more years to live, and so went through the surgery and did just fine. And so we really base that decision on the fitness of the patient. And, part of that workup that we do is to assess the risk so we can have an honest conversation with the patient about, look, I think the risk of the surgery itself is going to outweigh any benefit or in terms of longevity or health. But many patients, I think that I've done patients up to about age of 75. So we don't really have any age limit. I take it on a case-by-case basis.
Okay, well, that's great news. All right. Well, with that, I think we're going to go ahead and turn to our live questions from the audience. So either of you feel free to chime in once I read through the questions. So to kick us off for the first question here, this person is wondering, which, if any, surgery can someone consider if they've already had gastric bypass decades ago, but has gained substantial weight again?
Yeah, so this gastric bypass revisions are sometimes a little bit more of a difficult proposition, because if you revise it to one of the other effective procedures like duodenal switch, if you imagine, you basically have to reverse the gastric bypass, then do the sleeve and the duodenal switch. So it's a big undertaking that takes hours. The reported complication rate of that particular procedure is fairly high when it's been reported in the surgical literature. And so what we can do in a little bit more straightforward fashion is, number one, assess the size of the stomach pouch, because on occasion the pouch have been made a little bit large, or some patients will have a little bit of increase in the compliance of that pouch over time. And so we can go in either surgically, or our gastroenterology colleagues can actually go down with a scope and make that pouch smaller again to give patients more of that feeling of fullness and restriction. The other surgical thing we can do is actually bypass more of the intestine. So we can, and many of the operations that were done, gastric bypass in particular, that were done a while ago, had relatively short bypass limbs. So we can sometimes bypass a lot more intestine. Now, that comes at the cost of, we have to be more attentive to your vitamin replacement and levels, but we can actually get some more weight loss with that. The other thing I would emphasize is, with the medicines that we now have, we tend not to think of treatment as either surgery or medicine. We think of it as both. So these patients may get an endoscopic procedure to make their gastric pouch smaller. they may get a limb lengthening procedure, and they may get one of the newer weight loss medicines. And the combination of those therapies can then get them to their health goals.
Okay. All right. Thank you. Well, next question here. What type of doctor should we see for medication treatment? A primary care physician or specialist?
Yeah, good question. So I think if you have a specialist in your area, that's a great place to start. So just like our program, calling and scheduling an appointment with a specialist, especially if you're, looking for that comprehensive approach in the nutrition aspect of things. I think it's very helpful to at least meet with a dietitian who's familiar with the medication too, because sometimes nutrition looks a little bit different in combination with the medication. But I think, many primary care providers are very much educated in this field as well. So just having that open discussion, starting with your primary care, and they'll of course let you know, many might be aware of specialists that they work with or dietitians that they work with. So I think it's definitely reasonable to start the conversation with primary care, and they might know of a specialist in the area if they ultimately feel that would be best for your case.
Okay. All right.
Can I just add in on that? So for the first time in my career, we have medicines that for a good percentage of patients are very, very effective, and have a relatively low side effect profile. Because of that, the demand for these medicines, as patients probably know, is through the roof. And so we're seeing a number of access hurdles, getting to a provider that prescribes it, getting insurance coverage for it. I get those two things met, and then I get to the pharmacy and it's on back order. And then the last one is, some patients don't tolerate it. They have side effects. And so these medicines are a great new tool. And primary care docs are starting, are basically have started to prescribe these because the demand is so high. If you can get to a weight loss provider, the specialty, I think they oftentimes are linked with that more comprehensive treatment plan and dietitian counseling and follow-up. But I encourage patients to get, if they need those medicines, to try to go to their primary doc as a potential avenue for that.
And I see many people start with their primary care. They might be prescribed it, and then they kind of see us on a consultant basis as well. They might schedule that appointment. They might have to wait for that, but they start the process with primary care. And I find that to be a great way to kind of get the ball rolling and get you started.
All right. So definitely a few avenues there. Okay. All right. Next question here, a little bit more specific. This person says, if you take Ozempic for diabetes, can you take a weight loss medication?
Yeah, great question. So Ozempic is semaglutide, is kind of the generic name for it, and Wegovy is the weight loss brand for it. They are both the same medicine, just two different brand names when being applied for different conditions. So if somebody has both excess weight and obesity and type 2 diabetes, we're dosing the medication to treat both conditions. And so you would just remain on the Ozempic, and we would dose it both for blood sugar control as well as for weight loss. And sometimes we might switch medication depending on access, depending on coverage, and depending on effectiveness within the class. But if somebody has type 2 diabetes as well as excess weight or obesity, it really, we can change within the brands and things like that. And sometimes we do combine other weight loss agents with a medication like Wegovy or Ozempic as well. So definitely, even if you're on it already for type 2 diabetes, it might be being dosed for your blood sugar, but not necessarily for your weight. So definitely bring that up with your specialist or primary care provider.
Okay, thank you. All right, next question here. What is the downtime with bariatric surgery, and how soon can you return to work? I know that you talked a little bit about this before. If you don't mind just expanding on it a bit more.
Sure. Yeah. So the operations range in duration from about 1 hour up to about 4 hours. Obviously, if there's a revision operation, sometimes it can take longer. As we mentioned, most of them are done with a minimally invasive approach, and we're using a surgical robot, which we think reduces torque on the abdominal wall. We do regional blocks which are regional pain management, like numbing all the nerves that go to the abdomen. And with those, all the interventions that we do, the pathway that we have, most patients are able to go home just the next day after surgery. So just one night in the hospital. Many patients report, we do send patients home on a low dose of a narcotic pain reliever, but most patients report only having to take 1, 2, 3, or none of those pills, and many go right to Tylenol. I've had patients that haven't taken any of the narcotic pain relievers. So typically the incisional pain gets better fairly quickly. Many of our patients feeling well enough, if work does not involve heavy lifting or real strenuous stuff, many patients fit to go back to work, but just within about a week. And we typically see you the week following surgery, so we can, and everyone's recovers at their own pace. And so some patients we see the following week and they say, hey, I feel great, can I go back to work? And we give them a slip to go back to work. Others say, hey, this is worse than I thought, I need a couple more weeks. And we can easily justify up to about 6 weeks off.
Okay, thank you. All right, this person is wondering, could you talk a little bit more about the risks of surgery?
Sure. So, the field now of weight loss surgery, and this has been this way for quite some time. Now our programs seek to become what's called a center of excellence. What that means is we have an outside body, but basically that's run by the American College of Surgeons, where every 3 years they come to our program and they review all your cases, they review any complications that you have, they look at all your pathways with the goal of making sure that all the new knowledge in the field is disseminated and that we're as safe as patients as we can be. The operations have become safer and safer. The most concerning risks for these operations are any time we take out or operate on the stomach or in the bowel, and we create new connections or staple lines. Those connections have to be air and water tight while they're healing, and they take about 2 weeks to heal. If you leak from one of those areas, it's like having a hole in your bowel. It can make you sick and even be life-threatening. We oftentimes have to intervene again with another surgery. Now, fortunately, that risk when I started training in the late 1990s was up around 2 to 3% of patients were getting leaks after lap gastric bypass. That has now fallen to an order of magnitude less. So we're talking 0.1, 0.2%. To give you an example, I've been at Jefferson since 2010, and all my primary gastric bypasses, I've had no leaks. And all my sleeve patients, I've only had one. And fortunately, that patient recovered without any additional surgery. So the risks are down to less than 1% for leaks. There's always a risk of bleeding, other secondary infections like urinary tract infections, although those are also less than 1%. The other important risk for patients to understand is blood clots. And these are deep venous thrombosis or DVT and pulmonary embolus. Those are a risk that occurs with any kind of surgery, not just weight loss surgery. To prevent that, we do a number of things as part of our pathway. We give you a low dose of what's called prophylaxis blood thinner to help prevent that. We have these devices on your legs that if you've been in the hospital in the last 20 years, you've had those. They squeeze your legs periodically. That stimulates the release of a naturally occurring blood thinner. And then we try to have you walking within about 4 hours. With those interventions, we've reduced that risk of a blood clot to less than 1%. And again, we're close to 0.1 out of, not just 1 out of 100, 1 out of 1,000 for those. But those are the other potentially life-threatening risks. There are other risks, but those are the two most important ones for patients to understand.
Okay. Yeah, thank you for talking through that. Important to discuss, but overall, it sounds like good news. So thank you. Okay, next question here. Is there a specific bariatric surgery that helps improve diabetes the most?
Yeah, so the operations that has been shown to have the biggest impact, particularly on type 2 diabetes, is the duodenal switch. That's the operation that combines the sleeve gastrectomy with bypass of a significant percentage of your small intestine. Now, the SADI is a single connection version of that. The duodenal switch has 2 connections. The SADI has 1 connection. And it all depends on just how much of the intestine we bypass. Because SADI is relatively new, the data, head-to-head data comparing that to duodenal switch is not quite out yet, but those advanced operations have the best impact on type 2 diabetes. Gastric bypass also does a good job, but it's not quite as effective long-term as the duodenal switch and SOTI are. But that's the best data we have.
Okay. All right. We're getting a lot of questions, so thank you all for submitting, and we will continue here. The next question, how are specific bariatric surgeries determined for each patient?
So we certainly do that. Our surgeons do that on a case-by-case and individualized basis. Patients also get and I always say you get a vote. We talk about the pros and cons of if a patient has a choice. There are only a couple conditions where we may come down hard and say you really need to have this particular operation. The one condition is called Barrett's esophagus, which is a condition related to long-standing heartburn or reflux. What we know from the data on sleeve gastrectomy is that the sleeve is more apt to make reflux worse, not better. In addition, that Barrett's esophagus is a risk factor for cancer of the esophagus. And when we reconstruct, we actually normally would use the piece of the stomach that we take out when we do sleeve. So patients with that Barrett's esophagus, that's the one condition where I say, I won't do a sleeve. The only operation for you is gastric bypass in that case. That's a relative minority of patients that have that. And once you kind of explain the reasoning behind why you're making the recommendation, most patients understand that and agree. Other than that, patients, prior surgeries, other medical problems, how long we think the operation might take based on the choice of the operation, all those roll into the decision to say how we do the operation. As I mentioned, the sleeve can be revised to any of the other operations. And so patients with, advanced medical problems or medical problems that may put them at risk for just general anesthesia, like heart and lung conditions, we may decide to stage the operation where we say, hey, we want to do SOTI, but we're going to do it in 2 stages. We're going to do the sleeve first, let you lose a bunch of weight and get healthier, and then come back a year later and do the second half. If patients need that second half. So there's a lot of different options, and that's reached on a case-by-case and individualized basis.
Okay, thank you. All right, next question here. Does existing scar tissue from previous surgeries create issues for weight loss surgery?
So anytime there's prior surgery, there's I won't know how much scar is present and how much it's going to affect the impact until I kind of get in there. What we know is that there's likely to be some. Based on the history of what surgery it was, I may have an idea, hey, this is going to be a lot of adhesions versus less. That may help in counseling to say, number one, there's a chance I'm going to have to make a bigger incision on you and do what's called an open procedure, an alternate approach. We don't want to have to do that, but sometimes we do. That's less and less common now that we have the surgical robot. As I like to tell patients, I've done weight loss surgery on an ex-Marine that was shot through the abdomen with an AK-47 and had his spleen out in a colostomy. So you can do a surprising amount with minimally invasive surgery, but sometimes it's a little, I don't know how bad it'll be and whether I can do it or not until we kind of get in.
Right, absolutely. So again, talk to your doctor. Okay, thank you. All right, going to a question here about weight loss medication, a little bit more specific here. What are the most current benefits and risks of weight loss medications? And are there any specifically for postmenopausal seniors, or are they all the same? So looking just for some information on, the different options available.
Yeah, I think we have an upcoming webinar on menopause that I think might be helpful for you to watch as well. But just an overview, all the medications themselves, there's different types of medications, different classes, so they all come with different types of potential side effects. Many improve as you continue on the medication, but the newest class of medication, which more people are talking about lately, so Saxenda, Wegovy, and Zepbound, these are the injectable classes of medications. They come in an injectable form that you do yourself at home. And the most common benefits to them is typically you feel full sooner as you're taking it. How they work in your body is that they help to activate a hormone that we all produce naturally. That's called GLP. And basically, you know, Dr. Beakley talked about this earlier in reference to the surgery and how when they adjust the stomach and things, that affects one of the signals to the brain for fullness. And similarly, the medications can affect a different type of hormone in a fashion that's like that, where you start to feel full sooner, you kind of feel full with less food. Many patients notice less cravings. My patients would describe it as feeling less noise during the day to kind of snack, or overall just less appetite, which feels more manageable to them. And then some of the specific brands medicines like Wegovy has additional benefits to it, such as reduced heart disease in certain types of patients. So there's additional benefits getting into the intricacies on depending on the specific medication. With this class of medication, the most common side effects are nausea, reflux, or constipation, because the hormone that we're talking about is primarily produced in the stomach, kind of in the intestine area. And so where it's most activated, if you think about if you ever felt too full, the most common side effect of that is feeling uncomfortably full, nauseous, reflux. A lot of these side effects can really be counseled through, and I can teach you about how to eat with the medication, because if you think about it, if you eat slowly and mindfully, not eating too fast, trying to avoid really greasy, heavily starchy foods, it sits better in the stomach. You feel better with the medication. So a lot of the side effects get better as you continue and you kind of learn as you're on the medicine. And there's multiple doses to them, so the medicine can be adjusted as you go. Specifically for nausea, the rates are about 40%, depending on the specific medication. So a decent amount of patients might feel nauseous when they're on the medicine. However, less than 5% of patients actually stop the medication due to the nausea. So while nausea rates can be a little bit high, it's usually something that's maybe mild and bothersome, but it gets better as they continue on it. So that's kind of the most common of the newer classes of medicines that people are talking about.
Okay. Thank you. All right, this next one here, talking a little bit about when to consider surgery. Besides BMI, what other symptoms indicate surgery is necessary?
So that's an individual choice. I think we have the BMI criteria. With that in many cases comes a number of health or weight-related health conditions. When we start to add those up, type 2 diabetes, high blood pressure, obstructive sleep apnea, something called pseudotumor cerebri, which is a benign intracranial hypertension, joint disease, back problems. When we start to add all those up, the case for some sort of treatment really starts to go up. And you may decide, hey, weight loss surgery is going to give me the most bang for my buck. And again, we are not we're now thinking in terms of it's not surgery or medicine. It's going to probably be both. Just like we treat cancer with a surgery to take the cancer out and then chemotherapy afterwards, we may do surgery and then we may add a medicine at 1 year to kind of help maintain that weight loss. So that the decision to proceed with surgery as the treatment option is an individualized choice, and we can certainly help you reach that that decision.
Okay. Thank you. All right. We just have a few more questions here, and then I'll go ahead and share my final question for this evening before we wrap up. But before we do so, a few more questions here. Next one, sorry, let me see here. Okay, a question for if patients with AFib can have surgery or use medication.
Yeah, I'll start. Yes, you can take medications to manage weight. There is a specific medication that we wouldn't utilize for somebody in a history of atrial fibrillation that's called phentermine, or Qsymia, because that contains phentermine. However, the injectable class of medications are very safe for those with AFib. In fact, as mentioned, Wegovy specifically has that cardiac indication, meaning that those who have a history of cardiac events in the past that can reduce your risk of cardiac disease or a cardiac event by 20%. So specifically those with heart disease might benefit from the injectable class of medicines, and we would only avoid that one specific medicine I mentioned.
Okay, great news there.
Yeah, in terms of surgery, atrial fibrillation for us is not a showstopper. We actually have a very regular, active working relationship with our cardiology service. We operate on heart failure patients that have ventricular assist device and need heart transplant, so that they can lose. They have to get to a certain weight before they can get listed for a heart transplant, and so we do very patients with very advanced heart conditions. We do these weight loss surgeries on, and we typically will help co-manage with our cardiology service. Patients that have atrial fibrillation are on anticoagulation. Obviously, we have to stop the anticoagulation briefly for the surgery and then resume it once the bleeding risk is done. But that's not a showstopper for us either.
Okay. All right, talking a little bit about insurance again. Are all these procedures covered by Medicare? If you're able to answer that.
As far as I know, they're all covered now by Medicare. Yes.
All right, great news. Okay, last question here before we wrap up for the evening. What would the diet be post-surgery?
So there's the immediate post-surgical period. We have patients on a liquid diet. It used to be for a couple of weeks. Now it's, I think, 8 days of a liquid diet. And that's to protect all those staple lines from stress of solid food, so they're not stretched or stressed at all while they're healing. And so it's a liquid diet that can be protein shakes and so on, like that. And patients tend to feel satisfied with that diet. And then I think post-op days 8 to 18, they're on like a pureed diet, which is kind of applesauce or yogurt consistency. And then they go on to soft foods, and around 5 weeks, they start to reintroduce the regular foods again. So it's a graduated, more substantial foods as you go that first month or so after surgery. And that's mostly to protect the operation and staple line and allow it to heal properly. And then after that, the diet it tends to feature lean proteins, vegetables, and substantially reduced amounts of fruits. We typically tell patients to avoid blending fruits because that kind of just releases the sugars, and breads and pastas and starches, reduced amounts of those. It's not that there's none, but it's the diet it features kind of protein and vegetables. And many of our patients report having a wide variety of foods that they can eat.
Okay, so overall, great news. All right, we have one more question here before we wrap up. Again, about insurance. Some insurance companies approve oral weight loss medication initially before approval of the weight loss injections. Do the oral medications work?
Yeah, that's a great question. So what you're referring to is called a step therapy requirement. So again, if you call your insurance company and they say, yes, we do cover weight loss medicines, sometimes when we go to prescribe the ones that cause a higher amount of weight loss, which is the injectable class, they'll ask that we try the ones that are oral options first. And, in order to move on to the additional medication, we have to show that maybe it didn't work out with those medications, maybe there was a side effect or they were less effective. But they are still very effective. The medication, the purpose of them is typically to reduce the weight by 5%, because while we can have goals beyond that, the initial 5% weight loss greatly reduces risk of, whether it's high blood pressure, cholesterol, just the basics there that we're trying to improve. And so the orals can often achieve that 5% weight loss. Now, sometimes we kind of hit that barrier. We might not get additional weight loss, but it really depends on the patient and as we're adding in the lifestyle. But definitely, oral medications can be effective as well.
Okay. Well, thank you. And with that, I'm going to go ahead and ask my final question for the evening as we just about get to the end of the hour. So for the final question, what are your goals for everyone listening in on this webinar? What would you want our viewers to take away from tonight? And Dr. Beakley, we will go ahead and start with you.
Yeah, thank you. If it's been an enjoyable webinar, one of my first. But I think the important things to know, and I'll give you an example of the name of our service. It used to be minimally invasive metabolic and bariatric surgery. The name of our service is now Jefferson Comprehensive Weight Management. And what that means is that we are not just we're not just surgery. We're surgery, we're dietitians, we're nurse practitioners, we're medical weight loss specialists, and your treatment is likely to involve all of those. It's going to be a comprehensive treatment for your health, and that's the long-term goal of all this is health. And so we're going to help you get there in whatever way seems both best for you. We make our recommendations. As I said, patients always get a vote. There, we try to just give you the information that you need to make the right decision about your treatment and your health. And so, Caitlin and I, we shared a lot of patients because she has patients that have been getting medicine and eventually say, hey, I think I'm ready for surgery. I have patients that have had surgery and then say, hey, this person now needs some additional treatment to help maintain their success. And so that's going to be the new treatment model. It's not one or the other.
Okay. Well, thank you. And promising to hear that. So thank you. Okay. Kate, any closing remarks from you?
Yeah, I mean, I would really encourage patients to look at their weight, how they might look at something like their blood pressure. So if you went to the doctor and you noticed that your blood pressure was elevated, we wouldn't kind of jump into starting to blame ourselves necessarily on, oh, I ate that, it must have, elevated my blood pressure. You would ask your provider to kind of help explain why your blood pressure might be elevated. What are the lifestyle things we can do related to it? And do we need medication to improve it to live a longer, healthier life free of complications from that blood pressure? And that's really an analogy for how we manage our weight as well. It's not just what we eat. There's a lot of different factors that go into our behaviors and things like that. But some of us, have the genetics that we are more prone to gain weight. And sometimes these things are outside of our control, and you're not alone in that struggle. And it's not your fault. So I think it's really important to hear that and to know that your medical team is here to help you, just like we would help you with your blood pressure or any other aspect of your health. So I think it's important to come in and have the conversation. As Dr. Beakley said, we have multiple treatment options for you. And our job is to just lay them all out for you and make sure that you make the best informed decision. And I think that's one of my favorite parts of my job is getting to know the patient and what their life looks like, what their individual circumstances are, not just their medical history, to really come to that joint decision on what the best plan is going to be for them in the long term for their health.
Okay, well, thank you. Yeah, a really powerful and important reminder. So thank you for sharing that as we end the evening. Okay, well, thank you so much, Dr. Beakley and Kate, for your time this evening. Really, so much information was shared. I know I learned a lot, and I'm sure that our audience did as well. And thank you for attending and submitting your questions tonight. Again, such an engaging discussion, so we appreciate it. We will be posting an event survey, so you can let us know your thoughts, any other specialties you would like to hear from. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out the last question in the event survey. Be sure to visit jeffersonhealth.org to make an appointment to stay up to date on upcoming events and webinars just like this one and more. Be sure to also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics from back pain to robotic surgery to men's and women's health and more. A recording of this event will be sent to you so you can rewatch at your convenience. And if there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Thank you and have a wonderful night.